All right, well, we'll get started. Just wanted to say good morning. No significant announcements this morning. Lee is going to speak to us on a bunch of cases on renal injury and ischemia, so get ready. He's going to be asking you questions.
That's you, Dr. Goldenberg.
Me? I got to go get a coffee. Yeah.
Okay, well, thank you very much for that. This morning I'm going to be talking on renal injury and ischemia, and I'm hoping to go kind of review the pathophysiology of contrast-induced nephrotoxicity, renal ischemia, go over the risk factors predisposing patients to renal dysfunction, kind of basing it around a case of a small renal mass, and then finally, or kind of throughout, discuss the prophylactic and therapeutic interventions available to minimize the chance of long-term renal dysfunction. The first problem we run into in talking about renal injury is how to quantify renal injury. We know, most of us know that serum creatinine is unreliable, as it's both secreted and filtered. It depends on mass, body surface area, race, etc., and that for the most part we use estimated GFR, but again, that's not great, especially at kind of more advanced stages of renal injury. GFR, I guess, is the gold standard, but it's awfully cumbersome and not generally done in clinical practice. And that in the setting of two normal functioning kidneys, often it's because we don't have any serum or urine biomarkers, it's tough to know whether that kidney that we've operated on actually has suffered a renal injury or not, because the other kidney tends to compensate with the marker of creatinine. So we'll take keep this in the back of your mind throughout the presentation rather. That being a 55-year-old male with an incidental 3 centimeter small renal mass seen on ultrasound, a couple comorbidities which may predispose him to renal dysfunction with an estimated GFR of 60. So when you had that gentleman kind of arrive, your first step would be thinking to get a CT abdomen-pelvis, and certainly that's the gold standard for the workup of renal masses, that generally ultrasound is not considered enough to proceed with surgery, and that a triple phase or renal kind of protocol CT provides information on enhancement, the arterial and vasculature anatomy, the collecting system, etc. But that concerns arise, including radiation exposure, which is beyond the scope of this talk, and contrast-induced renal injury. Now in the past, MRI has been kind of our savior in the sense that if someone with renal dysfunction would come around, we just order the MRI with gadolinium and get all our anatomical information from that. But we'll touch on just a bit later, a new finding called NSF has come up, which has limited that option for us. So contrast-induced nephropathy is defined by a serum creatinine increase of greater than 44 micromoles per liter, that's just greater than 0.5 milliliters per deciliter, or 25% above baseline. The incidence is all over the place in the literature, ranging from 5 to 50% depending on the series, but also the predisposing risk factors. And then recently, and I guess that incident mostly applies to angiography, and that's where a lot of this literature comes from. Most recently, just within the last month or two, a series of outpatient CTs was reported with a incidence of CIN of 11%. And the doses of contrast material, just for interest's sake, on the angiography are, again, very variable. They range anywhere from about 20 cc's all the way up to 250 cc's, where CT using a renal protocol is in and around 120 cc's. Now this is just kind of a busy slide, but essentially it highlights three major points, and that being, and this is kind of just explaining the pathogenesis behind contrast-induced nephropathy. That being direct tubular toxicity from cytotoxic radicals, decreased renal blood flow from an imbalance between vasoconstriction and vasodilation. And interestingly enough, with vasodilation, the kidney actually becomes resistant to vasodilators, and that's limited our ability to treat or prevent contrast-induced nephropathy with things like dopamine. And finally, tubular obstruction from sloughing of epithelial cells. And on the left is just kind of a list of almost risk factors, that being decreased vascular volume, hypotension, nephrotoxic drugs. These are in large part the areas that we focus on in terms of trying to prevent contrast-induced nephropathy. Again, risk factors, most of us know these. At the top of the list for sure is renal insufficiency, along with increased age, dehydration, and the dose of contrast we use. It seems quite intuitive. So in the past, there's been a concern over using metformin in and around the time of a CT with contrast. In fact, it's not, the concern isn't that metformin causes the contrast-induced nephropathy, but that if it does occur, lactic acidosis may ensue, and this is reported to have been fatal in some cases. Now in the past, people have said, well, that's obviously a terrible outcome. You should just avoid using metformin regardless of the renal function in and around a contrast CT. That seemed to be a little too conservative, and now the current recommendation is to stop it before the study and then withhold it until 48 hours afterwards, checking the creatinine to make sure that it's still normal, at least at the baseline where you started.
How soon before the study, like the day before?
It's not really clear, but yeah, the day before is probably fine. You just want it to be started to clear so that it doesn't continue to build after you give the contrast agent. Okay.
Is it metformin for all CT contrast or just renal insufficiency?
Just renal insufficiency. In the past, it's been historically thought that you should just withhold it all the time, but really unheard of to have this severe lactic acidosis occur in the presence of normal renal function. Metformin is cleared by the kidney, and if the kidney's still working, you shouldn't have that problem.
What's the incidence?
It's, I'm actually not sure of that. That's true. Didn't come across a number.
All I've heard is that it's extremely low.
I would imagine, yeah. But I think it's more a matter of if it does occur, it can be quite serious. And so but yeah, I would imagine it doesn't happen all the time.
Just curious if one of the radiologists can comment. We don't do this at BGH, just for CT contrast.
We do this at BGH, sorry. We look at it. If we notice the creatinine is up, then basically we go on the protocol and go for the rest of the time. We'll help your craniums, first level.
So referring efficient condition is always contrast? What about 48 or 50 or 60? And then the condition contract.
Okay. So to prevent it, obviously kind of general supportive care, that being hydration. Then the use of isoosmolar, which is Visipake, that we occasionally use here but not very often, and low osmolar agents such as Omnipake we use in high-risk patients. And you try and reduce the dose of contrast if possible. Now the agent that's probably garnered the most literature is N-Acetylcysteine, and that's dosed at 600 to 1200 milligrams. BID starting about a day or two beforehand, and it's thought to work by both free radical scavenger and by vasodilation. Very well tolerated. Occasionally has some mild GI symptoms. Can cause bronchospasm in asthmatics. And the most recent meta-analysis suggests a relative risk of 0.62. That's based on 30 kind of controlled trials. Bicarbonate is the other agent that's used often at Vancouver General Hospital, and that's infused through an IV a few hours beforehand and up to 12 hours afterwards, thought to, again, decrease free radical generation. And the data is a little more conflicting here. They tend to be single-center studies. Some of them are positive, some of them are negative, but it's still part of the protocol here. And this is the protocol that's in use currently at VGH. And in this mild kind of dysfunction, again, pretty much across the board, you consider alternative imaging if possible. You stop nephrotoxic drugs, and then you start, as an outpatient, you give them NAC and then tell them to drink something like Gatorade an hour beforehand. If they're an inpatient, you can hydrate them with bicarb. And that's typically given with 3 amps and 850 cc's of D5W. You infuse it for an hour beforehand and anywhere from 3 to 6 hours following. Now this I thought was interesting, and if you have a patient who's really close to dialysis, but they're not on dialysis yet, estimated GFR less than 15, and for whatever reason you decide they really need a contrast study, hemodialysis can actually be effective at decreasing the incidence of subsequent dialysis, permanent dialysis, and a change of creatinine greater than kind of 90, higher than they started with at the time of discharge. I think you'd have to have very strong indications to proceeding with a CT in this sort of level of renal dysfunction. But this data was all taken from coronary angiography, where often it's a little more dire circumstances and you have to do it for the patient. Now, taking all that aside, you kind of look at what happens with these patients, and best I can tell, it's not all that bad. You support them by avoiding nephrotoxic drugs, you hydrate them, but that the serum creatinine increase seems to be transient and usually returns down to baseline kind of a couple weeks later. And that a persistent elevation in creatinine or progression to renal failure is really quite rare. So it really comes down to balancing the risks as to how much information you're going to garner from that CT and how important that information is in terms of your decision-making model versus the risk of having a transient increase and a small risk of permanent dysfunction from the contrast study. Now this is kind of what I touched on earlier, and that is this nephrogenic systemic fibrosis, which is rare but scary. Now the incidence again is higher than I would have thought, although it kind of even between kind of that 40 to 60 range, it's really not very common, 0 to 3%. But in these patients with very severe renal dysfunction, it can be upwards of 18%. And we'll get down to a little bit later. This is quite a serious condition, and not one that is not as certainly not as transient as the contrast-induced nephropathy. Now the agent we're using here, Multihance, which is a type of gadolinium, there's never been a reported case, but that being said, we're still going ahead with kind of very conservative measures as we try and find out more about this condition. The major risk factor, again, as we've touched on, is decreased GFR. Now the FDA came out with a warning just a couple of weeks ago, which says that the enhanced screening recommendations to detect kidney dysfunction at VGH, they won't do us between less than 30, they're really not proceeding with MRIs with gadolinium. Between 30 and 40 or 30 and 60 regionally, they are asking the radiologist to okay it. And if you really need a scan less than 30, there's actually a consent form that the patient has to fill out, which goes over the risks and benefits of the study, including the complication of NSF. This NSF, again, is featured by skin and joint contractures, fibrosis, and about half of them have severe disability, and it can be fatal, although the actual mortality rate isn't really known. The kind of tricky part is there's no known prophylaxis, no treatment. Hemodialysis doesn't appear to be protective. So it's a condition that rarely gets better. If anything, it stays stable and in many cases gets worse. So it's one to avoid. So this isn't really the scope of the talk. It just kind of sets, yeah.
On that topic, I wanted to ask Sylvia, perhaps talking to the MR folks at some of the large centers, they don't even check the creatinine. So then this is not an issue.
Well, what's interesting is, with our CTs, if anyone's going to get contrast, they all need GFR. MRI, we haven't done that. Part of it's because our wait list is more than almost a year. So if you get a GFR within 3 months, you're going to be brought in. Because this is so long, it's going to be GFR for 3 months for our patients. So we do screening when it asks if they're diabetic, they have any risk factor, risk factors.
Mm-hmm.
And so forth. And if they say yes to any of these 6 standard screening questions, we need to attend GFR. So for most young patients, frequency of renal screening would go ahead and
Sure. Now, I wonder if that might change even in some of the larger states in the centers in the States with this new FDA warning. That's only 2 weeks old, so.
What's interesting with some of the CT data is because we generate EGFR in all patients, we come across quite a few patients who actually have GFRs of less than 30, and they have no history of diabetes or no history of renal disease. Fortunately, all of these had GFRs above 30, so in terms of risk of NSF, these had GFR less than 40. Unfortunately, all of these had GFRs.
All right, so options for small renal masses are anywhere from surveillance, radical nephrectomy, that via a number of approaches, laparoscopic or open, partial nephrectomy, which is certainly becoming more common, and ablative techniques, which are being used clinically but still kind of in evolution, that being RFA and cryo. Now, partial nephrectomy doesn't take long just to kind of look through a couple slates at at Vancouver General to find out that this is really gaining traction as a modality of choice for small renal masses. And why are we interested in it? It takes more work, it has higher complication rates, takes longer, certainly more stressful. Why is it that kind of policymakers such as the NCCN are going beyond kind of the traditional indications, that being kind of something that would predispose this, would leave this patient on dialysis, multiple primaries, solitary kidney, renal insufficiency, to including things like selected patients with small unilateral tumors, so-called elective partial nephrectomies. And AUA takes it even a step further, and they say that radical nephrectomy is greatly overutilized in these small renal masses, that partial nephrectomy is now considered the treatment of choice, even in the presence of a normal contralateral kidney. And really, it's for these next few slides really explains why that's the case. And certainly, this is quite a dramatic slide in the terms of renal functional outcomes. That over the course of kind of 8 to 10 years, you see a dramatic difference in the probability of freedom, that being defined as a GFR less than 60, between partial nephrectomy and radical nephrectomy. Necessarily, all these studies come along with the caveat of a very strong selection bias. The guys who are getting the radical nephrectomies might be older, they may have more comorbidities, et cetera, but certainly that's a gap that at least makes you take notice of this treatment modality. And again, here's just a further study out of the University of Texas Southwestern, again looking at T1A lesions, dramatic difference between either ablative techniques and RFA versus radical nephrectomy. Now, the concern when we first started this was whether the oncological outcomes would be equivalent. And see those two lines at the bottom, that being radical and partial nephrectomy, renal cell carcinoma-specific mortality, are nearly identical. So the oncological outcomes appear to be normal, or appear to be equivalent, rather. But what's interesting is that partial nephrectomy is actually associated with an improved overall survival, and this is in large part thought to be due to the improved renal functional outcomes. But again, you kind of have to keep in your back of your mind that this may just be selection bias. And there's never been a randomized control trial comparing the two, and likely never will be. Now, it follows that people started with T1A lesions, these little kind of incidentalomas, and people over the years have kind of pushed the envelope and are now looking at T1B tumors. And again, looking at the top left, there's a difference in overall survival between partial nephrectomy and radical nephrectomy, and even a difference in cancer-specific survival between partial nephrectomy and radical nephrectomy, which I find kind of harder to explain. Maybe we'll get some comments at the end why people may think that that's the case. So, partial nephrectomy being kind of a treatment of choice, there's still some kind of considerations we need to take into account, and that being renal ischemia, really number one. And we've known for a long time that taking the blood supply away from a kidney is not good for a kidney. And first was reported in kind of the transplant literature and also an open AAA repair, whereas if you had the clamp across the aorta and subsequently the kidney for greater than 50 minutes, really you were almost surely to have azotemia. But again, most of these patients tend to be pretty sick, tend to have preoperative nephropathy, which would have predisposed them to renal injury. And we know that ischemia is the strongest modifiable surgical risk for subsequent renal dysfunction. And that if your GFR is good, that if you manage to keep your warm ischemia time under 20 minutes, which is also quite short, really the chance of a increased or decreased GFR post-operatively is slim. Now, up until a couple days ago, I had a slide on there that we don't really know about a dose curve in terms of how much is too much. And that all changed last month with the publication of again, a retrospective study, but looking at over 300 patients, median preoperative GFR of around 60, a median ischemia time of 21 minutes. Most of these patients had their partial nephrectomies done open, and that's really the case in most of the literature, is because it's still a developing technique laparoscopically. And they first looked at their data with a continuous variable and noted that for every minute longer, your odds ratio was 1.06 for acute renal failure. And then they kind of categorized their data into 5-minute increments and found that 25 minutes was kind of the time which best differentiated kind of good renal outcomes and not so good renal outcomes. And this is kind of shown in a graph here, whereas if you manage to do the clamp time and your ischemia time in under 25 minutes, you have a much better chance at survival of survival-free outcomes less than of a GFR less than 30, versus if you take longer than 25 minutes. Yeah.
Going back, you've got me friends on those patients with 61, and they're all
Yeah.
moderately low, so I would say that you can't take that much unless you have a person up here with your got me friends.
Oh, exactly. You're right.
Time use for an hour, and you come down.
And I can't argue that because there really isn't much.
We've seen it historically, because we didn't have this information to start a transplant. There were times for a long time.
Yeah.
So I think that's those are ischemic on damaged kidneys.
Yeah. Right. And this data doesn't really split up kind of, they don't really do a subset analysis, which would have been interesting in taking kind of those patients with a GFR greater than 80 or greater than 90 and seeing how they did. But it still holds, I think, that you want to do it in as quick a time as possible. But 25 minutes versus 30 versus 20, again, it's up for debate.
Who cares? I mean, the attitude has to be there, you're there to cure
Yeah.
the cancer.
Yeah.
You're hustling and making mistakes.
Yeah.
You know, there's a whole different attitude towards doing it properly and doing it
Oh,
fast.
sure.
So I think you should, that's a thing that should get out of your mind.
Sure.
Do it fast, and do it still do it well. Don't do it fast and do it.
Fair enough, yeah.
But this is warm ischemia. Right?
Yes.
So we know that 25 is the threshold, we think we longer than cold ischemia.
Yeah.
Well, laparoscopically, we want to cold ischemia.
That's why it's nice to be open.
All right, so we'll just touch on pathophysiology, which is pretty dry stuff. But that really, there's not a whole lot of human data on this. And that we're not rats, we're not pigs, that the architecture of the kidney varies, the inflammatory responses of the kidney varies, the renal blood flow autoregulation varies. And it really impacts on our ability to develop preventative interventions, because if you test it on a kidney that's not a human kidney, you don't know if that's really going to hold true in the human model. So it results really from a vascular and tubular injury in a combination of these two. As the endothelium gets injured, it changes the response to vasoactive substance, which I touched on earlier, kind of an increased response to vasodilators, and it's resistant to, or vasoconstrictors rather, and resistant to vasodilators. There's an upregulation of an inflammatory response with adhesion molecules, lymphocytes, platelets, leading to small vessel obstruction. And then sloughing of tubular epithelial cells leads to tubular mechanical obstruction. So it's really a four-phase process, which carries through beyond kind of when you take the clamps off. The inflammatory cascade doesn't just stop as soon as you take that restore blood flow. That when you put the clamp on, as you understand, the depletion of cellular ATP with cellular electrolyte shifts, cellular swelling, free radicals, inflammatory response. Then when you restore it, it actually triggers the release of, again, more cytokines, reactive oxygen species, leading to further injury. And this eventually kind of starts to resolve through the maintenance phase and then through the repair phase as well. And I don't actually know the timeline of this. It's not really clearly elucidated in the literature I saw. Now, I'll touch just on some surgical approaches and techniques. So I guess the most important part about this slide is whether you're doing it open or partial or robotic, your partial nephrectomy, while that can vary, your ischemia time really shouldn't vary. That if you don't think you can do it laparoscopically in an appropriate amount of time, you probably should do it open. And if you don't think you can do it laparoscopically, you do it robotic if you think that's going to be easier. The open and laparoscopic, this is really intuitive, that open, tends to be used in high-risk patients, although that is changing, associated with higher blood loss, longer operation time. They tend to be in hospital longer and require more opioids and analgesia. Laparoscopically, obviously minimally invasive. They're quicker to recover, but it does have a higher reported complication rates and longer ischemia times. And robotics, really just an evolution. There's not a whole lot of data on it at this point. So laparoscopy, just from a physiological point of view, is known to cause a transient decrease in GFR secondary to really compression of the parenchyma and renal vein. And that decreases the renal blood flow and cortical capillary perfusion with subsequent transient oliguria. It was all kind of from dog model kind of stuff. But it's a myth that really makes much of a difference in the long term. That at the kind of renal pressure, at the intraperitoneal pressures we're using, typically between 12 and 15, the effect is really negligible, and that in the long term, laparoscopy does not cause renal dysfunction. Now, this is really the only series that I've seen. It's actually just an abstract form at the present, so there's not a whole lot of, this is kind of the gist of the data. I don't know really anything more. And surprisingly, laparoscopy was associated with a shorter ischemia time, although again, a huge selection bias because there's fewer hilar tumors, fewer posterior tumors, those kind of being the two primary causes of a long ischemia time and being technically difficult. And a lower 2-week rise in the serum creatinine, which is probably just reflected from the ischemia time difference, but that no difference at 3 months, which is probably what we should be looking at more than kind of a transient increase. Now, clamp techniques, kind of most often we just clamp the renal artery and the renal vein either on block or individually. There have been a few kind of alterations of this which have been investigated by various people over the last few years. The first is just clamping just the artery with the theory that you get some backflow from the vein and that'll help with ischemic injury. Really, there's not any evidence to suggest this helps, and that it probably, if anything, impairs your ability to visualize the tumor and resect it, and probably not something that we need to be doing. Yeah?
A lack of evidence to say it helps doesn't mean there's evidence to say it doesn't help, right? Just
Fair.
let's study that.
Fair enough, yeah. Yeah?
And if you don't clamp the artery, not the vein, it's easy to see the veins flow over when you repair it. You see these little things with little blood coming out. So when you clamp them both, all you see is slits and holes. You don't know what it's what.
Fair enough, yeah, okay. So, really the group out of the Cleveland Clinic has looked at two variations of the clamp technique, and that being an early unclamping technique, and that being you place a parenchymal suture, typically in running fashion, and then you take the clamp off to place your capsular sutures. And they've shown a decrease in ischemia time really in half, from about half an hour to just under 14 minutes, with improved renal outcomes being reported at this year's AUA. Doesn't say in the abstract how long the follow-up was, but it'd be interesting to see exactly what they find here. They kind of, if that was kind of a fancy car, this is more of a concept car, and that being this no clamp technique, that you just attempt to do the partial nephrectomy with no clamp on there. And I've heard just in speaking with one of their fellows that they've been using it with induced hypotension, although I haven't seen that reported in the literature. And the pros, obviously, pretty obvious. No ischemia seems like a good thing. I don't know, they ask Anna, would you kind of wonder about in terms of what might be happening to the contralateral kidney as well if there's no blood going to either of them? But again, that's more just hearsay. I just talk to them, or you let the surgeon kind of just go for it and induce hypotension that way. Then the cons, obviously, is there's concerns over visualization of the tumor, positive margin rates, and blood loss. Now, there's kind of two different populations that have been studied with this technique, that being kind of two normal kidneys. Again, in a retrospective analysis, no differences in renal outcomes were reported, and just slightly more blood loss in the no-clamp group. Now, in solitary kidneys, this was just reported within the last month or two as well, again, a retrospective analysis, with a medium ischemic time of 21 minutes, which is quite short. And they actually showed better renal outcomes in the no-clamp technique versus the clamp technique, and no difference in complications. And really that's held true in both of these groups. There's been no difference in delayed bleeds, in positive margin rate, recurrences, etc. And again, just that slide kind of showing better renal outcomes in the no clamp technique versus warm ischemia in the range of kind of 20 minutes as a median level. Again, quite a dramatic difference. These are all done laparoscopically. Yeah, which again, we'll touch on that kind of in our conclusions, that even if this exists and it works, and if you're not comfortable doing it, then it's not a good technique for that specific surgeon. Now, this is kind of to follow up on Dr. McLaughlin's point. A tough case, you may think, like, this is a really complex tumor. It's doable, but I'm going to have that clamp on there for way too long, and I should just take the kidney out because I'm going to have the clamp on for 40 minutes, and the kidney's going to be dead anyways. Whereas it doesn't really seem to be the case. This doesn't really show up great, but on the left it says the percentage of the latest GFR, less than 45, and then versus the partial nephrectomy with the extended ischemia, and that was, the median was 36 minutes and ranged anywhere from kind of 31, which was kind of, they defined as greater than 30, all the way up to over 100 minutes versus radical nephrectomy. And the decrease, those only 19% of the extended ischemia patients had a GFR less than 45, whereas the radical nephrectomy group, 35% had a group. So even if it's a tough case, if you think it's doable, then you can probably should proceed with a partial nephrectomy. The other alternative is using cold ischemia, although it seems to be being done less and less commonly, and likely not necessary if your warm ischemia time is, they say 20, but you want to wonder if even you could extend that a little bit further. The techniques, we almost exclusively are doing this in an open approach with slush, and if you keep the kidney in slush for kind of 10-15 minutes, you can get it down to a level around 20 to 22 degrees Celsius homogeneously through the kidney, which is about kind of a practical level to get to. Now the optimum temperature is 15, but that's quite difficult to reach. Yeah, Mike?
Just one more comment about just another way that
Mm. Sure. Hmm.
The downside of that obviously is a lot of irrigation and
Yeah. And they're doing that presumably with the clamp on?
yeah.
Now again, reaching this kind of 20 to 25 seems to be adequate to providing you up to 3 hours of warm ischemia time, and either with the irrigation system or just some slush in the open model seems to be adequate. And we'll just touch on kind of the renal protection options available, and they'll be only touched on briefly because really the evidence I was surprised to find was really lacking. It makes sense that you maintain a blood pressure that's at a reasonable level, you hydrate them, but that in the furosemide group, really there's really just theoretical evidence in the partial nephrectomy population that's thought to wash out some debris, promote solute loss, and it all kind of acts via alprostadil release, but really it's just a guess that this works in the partial nephrectomy group. Yeah.
That's interesting because when we started transplant, everybody got high dose, 400 milligrams.
Mm-hmm.
And we actually, so it's never been proven. It's just not real. Nobody gives Lasix anymore. Is that right?
Yes, well, certainly I'm not entirely clear on the transplant population, but certainly in partial nephrectomy, there's never been even retrospective analysis on whether Lasix increases or improves renal functional outcomes. Really the same with Mannitol as well. There's a little more evidence within the transplant literature that this works, but again, it's never been studied either in a prospective or retrospective way in the partial nephrectomy group. And it works through a number of different mechanisms, that being flushing out CAS via diuresis, reducing cell swelling, and scavenging free radicals. Should be given kind of 5 to 15 minutes before arterial occlusion from, again, some animal studies done by Collins. Dopamine, which is also occasionally used. This is the one group that in the partial nephrectomy kind of population, it was done with a small randomized controlled trial and didn't make any difference on renal functional outcomes versus control. Again, quite short follow-up, but presumably if there was no difference in 4-day follow-up, their presumption was that there was no difference kind of down the road. That would just be kind of affecting acute kidney injury. So other myths, other bad ideas. People in the past have tried capsulotomies for reasons unbeknownst to me. This intermittent clamping as a way of preconditioning the kidney to the insult that's coming its way. Again, isn't been shown to work within a kidney model. Rather than clamping the kidney, people have described just kind of squeezing the pole of the kidney to try and cut off the blood supply. And that's been shown to actually cause more acute kidney injury. And there's also kind of this thought, and it's reported in Campbell's as well, that solitary kidneys are more resistant to ischemia. Really, this is based on pretty anecdotal evidence. And in such a high-risk population, I don't think you should hang your hat on that finding. Lucky he's not here as well. Dr. Ng should have warned me about that beforehand. I think he was setting me up. Finally, just one quick slide on post-operative NSAIDs. We worry about it in patients with obviously kidney dysfunction, patients with coagulopathies. But in patients with normal preoperative renal function, there's really no evidence to suggest why we shouldn't use them. It decreases opioid use. There's no difference in renal functional outcomes in this prospective database, which kind of looked at about 150 patients. The thought is that it blocks prostaglandin synthesis, it subsequently blocks the cyclooxygenase pathways and causes renal vasoconstriction, but that hasn't really played out in the literature. So patients who have had partial nephrectomies, who you think who have good hemostasis, have normal renal function, and should feel safe using ketorolac. All right, so just some brief thoughts. Contrast-induced nephropathy prevention is not 100%, but certainly does help in patients at risk. Now you really need to take the risk of CIN in context with the patient as a whole as to whether or not that imaging is really necessary. And if there's a risk of CIN, the patient's care really depends on that imaging study, then maybe it's still the best move to go ahead. Renal ischemia certainly the evidence suggests that we should be nephron sparing whenever possible. That the approach and the clamp technique is, although there's all this evidence suggesting that one way is better than another, really it's a surgeon-specific thing, and you do what it feels comfortable for you to keep the patient safe. That it does make sense, at least in these patients with GFRs that kind of borderline, that every minute counts, and that while you shouldn't be fast, you should be efficient, and that all these renal protective measures that are commonly used are really unproven within the partial nephrectomy group. So that's the end of that kind of portion.